I'm going to give a presentation. I was given the title, which I actually felt was a bit of a loaded title, really, depending on your role and what you think about nurses and nursing. But I do believe that now is a really good time to reflect on infection prevention and control, because we have just been through and are still going through, because the pandemic is not over. Yes, we are living with COVID, but the pandemic is not over. And everyone is acutely aware of infection prevention and control, and everyone has a view on infection prevention and control. And many of you will recognise that, whether it's the public, your family, the people you work with, the managers, everyone is talking about infection prevention and control. So in preparation for this presentation, I asked myself some questions. And I felt these were important because infection prevention and control does not sit within a silo. And you've heard some great presentations today, and if you were here yesterday, about how we can integrate infection prevention and control for the better. So today's based on a lot of reflection. I did discuss this presentation with my peers and colleagues at the Royal College of Nursing, because bringing the perception of non-specialists to a specialist subject is really central in making sure that we continue to meet their needs. We are there to support our colleagues. So, what are we trying to achieve in infection prevention and control? This is the definition that is on the WHO website around infection prevention and control, and I've highlighted some of what I think are important words within that. So it's a practical area of practice. It's there to keep patients and staff, importantly, safe. It talks about harm from avoidable infections. Can you tell me what an avoidable infection is? Is an avoidable infection one that we are scrutinised about or monitored on by government targets or the targets of managers? Do we monitor every avoidable infection? Do we assess every infection to see if it was avoidable? No, we don't, because our surveillance systems aren't that accurate. So I have a bit of an issue with the word avoidable at times. It's universally relevant to everyone, and that is why infection prevention and control should not sit within a silo. So preventing infection is complex and multifaceted, and it extends beyond the boundaries of the physical environment, the health and care environment that WHO referred to. So their definition of infection prevention and control is very much focused on where health and care is delivered. In my world, at the Royal College of Nursing, I need to consider infection prevention and control beyond the boundaries of the physical environment. And it's about, for me, the relationship between the provider of health and care, the wider environment of care, and actually the local community, because patients' care doesn't begin and end in a hospital. Their care pathway goes often on many occasions between their home or where they live, their care home, for example, the hospital, the community clinic, and back again. So there are no boundaries when it comes to infection prevention and control. Increasingly, infection prevention and control is seen as a key influencer in what we talk about in terms of the social determinants of health. And that's because there are a large range of risks associated with health that result in people being admitted to hospitals. So for those of you unfamiliar with some of this language, the social determinants of health are loosely described as the conditions in places where people live, learn, work, play, and they affect health. So if you live or work in an area of severe deprivation, that will have a direct impact on what people are admitted to your hospital with and the conditions which they present with. So we cannot separate our hospitals from our communities, and within that, infection prevention and control, and subsequently antimicrobial resistance. So the interconnectedness of infection prevention and control is key, and we need to think about that in terms of nursing skills. So nursing, what is it and what is it not? And you'll be aware of many different perspectives currently around nursing. Nursing is predominantly, but not exclusively, a female profession. And recent attention as a result of the pandemic and also industrial action for better pay and conditions has ignited many views on the historical construct of nursing as a vocation and the gendered implications that go with this. Now, this is not a political statement, it's actually the reality. It's reignited the debate on care, vocation, reward, and importantly, the personal attributes and skills that nurses need to deliver care. Registered nurses are, and midwives, degree-educated, highly competent, multi-skilled professionals who share a sense of purpose through the provision of emotional, physical, and mental well-being. It's actually really hard to define nursing. The challenge has been, to date, how to describe nursing in detail in a way that complements but does not reduce the intellectual requirements for that role. We also need to acknowledge the skills of our unregistered workforce, our healthcare support workers, our cadets, for example, that support us in our roles, and we cannot do our job without them. So the skills should transcend those issues. So this slide comes with a bit of a warning. I recently had a conversation with a colleague. We were talking about something she wanted to implement in clinical practice. This nurse works in an NHS trust. And we were talking about IPC specialists because she was trying to bring the IPC team on board and she was running into quite a few problems. The discussion focused on nurse-led projects and the skills that IPC and nursing could bring to this. And she made a statement to me. At the end of the conversation, she said, yes, but they're not nurses. And I thought, wow. She was referring to the infection prevention and control team. And I was really shocked. I wasn't shocked because I have heard this before, but I was shocked because of who it came from. And this was not a throwaway comment. She was able to articulate very clearly why it was that those nurses that she was referring to were not demonstrating the skills that were important to her and she recognised in her nursing colleagues. So it was a real moment for me and really made me sit up and listen. So the perceptions of people, the perceptions of nursing can be a barrier to us actually doing our job. And in infection prevention control, that is absolutely essential. It was, in fact, a damning view of infection prevention and control. So I went away and I posed this question to my colleagues. And these are my colleagues that work with me at the Royal College of Nursing. There are 10 of me. We work across all spheres of nursing practice and in all communities, from prisons to mental health to learning disabilities, public health, you name it, we support those areas and we work together across them. And this is what they said. So I posed the presentation question, and what you can see here are the answers that they give. So the lens through which they answered the questions very much focused on not specialist nursing, but actually what it means to nursing practice to do good infection prevention and control. And I felt that this was a really positive reinforcement of the implementation of infection prevention and control in practice and the skills that we need to do that. So I took these responses, and they know I'm giving this presentation today, and I reflected. My colleagues didn't talk about technical knowledge, skills, evidence-based guidelines, or specialisms hierarchy or rank, whatever you want to call it. They are clear that preventing infection is core to nursing practice, and we do talk about nursing as the largest safety critical profession in health and care. We make up the vast majority of healthcare professionals. They are absolutely clear that considering the prevention of infection has the patient at the centre, at the core of nursing practice. Guidelines and policies inform care, they don't dictate it. Infection control technical guidance can feel very removed from the person, the patient, the carers, or the environment of care, and there is no one size fits all. Implementation, producing guidelines and policies without implementation plans will not result in the implementation of guidance and improvements in care. And listening to healthcare professionals is absolutely key. In my world, we talk a lot about equality and diversity. I have to do multiple assessments alongside equality and diversity. What's clear to me is that diversity is often associated with race. Diversity is not just about race. Diversity is about opinion and perceptions. And once you realise that, and you look at and do an assessment of equality and diversity, it brings a completely new perspective. So my colleagues are great in supporting me in my role. What's clear is that we live in very different worlds. In infection prevention and control, you are a big fish in a small pond, but to my colleagues that support me, actually infection prevention and control as a specialism is a small fish in a big pond. And we need to span both. We need to be able to translate both and be recognisable in both. So we have to be acceptable to our colleagues, and we have to acknowledge that we sit within a range of priorities that they have to consider on a daily basis. So, what makes nursing unique? Well, it's actually very difficult, as I've said, to define nursing. The first definition of nursing was published in 2003. And when I went back to look at this, because the RCN is about to republish the definition of nursing and a revision of the principles of nursing practice, they'll be published at Congress in a couple of weeks' time. I remembered the furore that resulted when the first definition was published then. And it was really interesting to see how other professions reacted to how nurses had defined nursing. And once we defined nursing, because this is not an academic piece of paper, it's a framework that we can then implement and ensure that we have the skills to deliver patient care and map ourselves against these. So I can't give you the new definition of nursing today, I'm sorry, but I've summarised what I think are some of the core elements, so you can have a look at these. So the first bullet point talks about registered nurses, and of course it reflects, because we are an evidence-based profession. Evidence can be research, but it can also be lots of other different types of evidence. We use clinical judgment to assess, plan, implement, and evaluate high-quality person-centred care. So that's a good starting point. We have many different roles in nursing, so not all of these are applicable to everyone. So not everyone is responsible for coordinating care, for example, but we all work as members of multidisciplinary teams. And together, we bring our nursing skills to make sure that the patients, their carers, and their experience of care is absolutely what they would hope it would be. We have what we call therapeutic relationships, and actually therapeutic relationships also apply to our stakeholders, those that we work with. whether it's colleagues, whether it's informal or a formal relationship with others that you need to work with. So this is the beginning of us being able to describe the skills that we have and therefore start to look at infection prevention and control. It's good to say that actually we've come quite a way since the early days of nursing. Now, I was looking at a presentation from when I started at the RCM. I hope you're looking at this carefully. And this actually came from a presentation of a colleague of mine who was trying to describe the benefits of a new type of specialist nurse, and that was a specialist nurse in sexual and reproductive health, supporting women that wanted to terminate their pregnancies in the early stages at that time. It was a very, very difficult thing. So there you can see that in 1905, nursing skills were restricted to tasks. We still do tasks. We don't do some of these necessarily, but we still do tasks. But this was clearly aligned to gender and the association at that time between gender and what could be described as subserviency. So it's one of its kind. But we've moved on. So, as nursing's evolved, so have our health and care services, and the demands for our health and care services have increased significantly. So here you can see A&E attendances and spend. This is from a publication a couple of years ago, but it gives you an idea, and you'll all be aware of this on the ground, of how demand has increased exponentially. So how is infection prevention and control going to manage, because demand is going to keep going up? And new demands are going to come as well. We have to, whether you want to or not, consider the impact of climate change on our health services, and the wider environment. And infection prevention and control is no different. It has to adapt. Demand for health services are going to increase due to climate change, not just because of the way that infectious diseases epidemiology will change, but because physical and mental health demands as a result of climatic change will result in people presenting at GP practices and hospitals, for example. And anywhere a patient presents or receives care is an opportunity for infection prevention and control. So if we don't start thinking now about the future, we risk chasing our tail. Are we really going to continue doing audits, writing policies, writing guidance, doing what we do now as our business as usual, whilst everything piles in on top of us? We have to think more differently about prevention, and prevention in its wider sense. So what does the future hold? Well, here you are. I was going to make a comment on the new NHS uniform, which is going to be coming out soon, but I don't think it was. Actually, the uniform looks really nice, and they've done a fantastic piece of work on this. But no doubt technology will have a role, and our skills will need to adapt and adjust to meet those as nurses, not just in how to manage equipment, but how to support the patient receiving this care. But the hospital of the future, most likely, is going to be the patient's home. How are we going to manage when over 70% of the world's population are going to live in urban settings? By 2050, we estimate that approximately 70% will live in urban settings, and there will be new designs to accommodate this number of people. That's up significantly from now. This compares with 751 million in 1950 to 4.2 billion in urban centres in 2018. So the opportunities for the spread of infection in large urban settings is significant. We have to think about preventing infection before people get to hospital. We have to start thinking about the promotion of health to keep people out of hospital. And we have to think about clean air, clean water, clean buildings as part of that, even though it's not in relation to health and care within the four walls of a hospital. So IPC needs to think differently. One of the ways that we can think differently is by taking a holistic approach. And actually now is, again, a good time because we have new systems in place through integrated care systems where we're starting to look at the needs of local populations and how we can manage care services differently. So adaptation and integration into these new structures now is a really good time for infection prevention and control to think differently. So, back to where we started. What nursing skills can we will bring value to these future challenges? I've listed some here, and I've reflected on the comment that was made by my colleague around infection prevention and control specialists not being nurses. The most important one for me is listening. Hearing is different to listening. We have to listen, we have to acknowledge, even if we don't agree. Listening is a core skill that nurses have. We do it with our patients, we do it with our relatives, we have to listen to our staff. Nursing knowledge, skills, professional judgment and experience will be key in informing holistic patient care and considering the needs of our populations. We will always retain specialist skills. There will always be a need for infection prevention technical skills, but the more strategic roles will look different in the future, I predict. We will still lead, organise and deliver services. We will still translate and implement guidance, but they will be done in a different way. So coming to an end now, I really believe that now is a really exciting time to be in infection prevention and control. I've been in this speciality now nearly 20 years. And actually, if I was to start all over again, I would do, because there are huge opportunities if you are interested in infection prevention and control. It's not going to be easy, but it is going to be a fascinating journey. So now is the time to be excited about infection prevention and control. But you do need to be able to embrace new ways of working, new ways of thinking. You're going to have to be braver. You're going to have to ask more questions, and you're going to have to take more time to bring people with you. The greater diversity in IPC roles in the future will bring future opportunities, and we have huge transferable skills, and these are what make us adaptable. So the lead and consultant nurses of the futures will be key influencers in population health in order to reduce the burden of infection where health and care is delivered. Thank you.